I want to thank you again for attending another grand round for the Transplant Institute Lecture Series. I'm Dr. Marwan Albazoud, Director of the Transplant Institute. And it gives me a pleasure today to introduce our very own, Dr. Ahmed Nassar, going to give us our grand round today. Many of you have worked with Dr. Nassar. He's a transplant and hepatitis surgeon here in the Transplant Institute and also at Children's Hospital of Michigan. And he finished medical school in Alexandria, Egypt, a beautiful city for those who have not traveled, on the north coast of Egypt. And then subsequently, he went on to do research at the Cleveland Clinic and stayed in the United States for medical school and then residency as well. His fellowship was at Emory University in multi-organ transplantation and pediatric transplantation, but he also stayed on faculty, and we managed to have him come to Detroit, which was a tremendous asset for us. He's an assistant professor in surgery, and his main interest is in normothermic regional perfusion, organ preservation, and this was the area of his research at Cleveland Clinic, which is a reputable center with that kind of research work. They developed an animal model and led to a lot of publications with a lot of studies that even was translated later on to the clinical model that we all know currently. So he's currently the director of pediatric solid organ transplant at Children's. He's doing both pediatric livers and kidneys, and he's done phenomenal well, and I'm very proud of him for doing that. He also is leading multiple studies in normothermic regional perfusion, as well as the ex vivo normothermic machine perfusion. He championed the NRP, normothermic regional perfusion program at Henry Ford, which has been in the works for the last 5 years. And now we're hoping to be a leading center in that effort. And he also serves with the American Society of Transplant Surgeons in the Standards and Quality Committee. So without further ado, thank you, Dr. Nassar, and we're going to hear about normothermic perfusion, redefining organ preservation, and transplant success.
Thank you, Dr. Albazoud, for the kind introduction. So these are my disclosures. So before we start talking about normothermic machine perfusion and normothermic regional perfusion in general, we need to define what are the types of donors that we have. And those fall into 3 categories. The first category being living donors. And living donors are, as we all know, when someone donates part of the liver or the kidney for transplant, which those are not included in our talk today. Then there's donation after brain death, in which those are donors that are deceased donors that have loss of brainstem reflexes, and there is cessation of flow in the cerebral circulation as well. And the second category is donation after cardiac death. And those are the donors that have significant neurological damage present clinically and confirmed on imaging, yet it's not sufficient to meet brain death criteria. And that group, that subgroup here, is going to be the main interest of our topic today. And the reason why, or the importance of DCD, or donation after cardiac death, and looking at it from a different angle almost every year, is this graph over here. So as you can see in the blue lines, the blue bar chart, are the donation after brain death donors. And between 2013 and 2023, the increase was only from 8,000 donors to 10,000 donors in the US. Now, looking at DCDs, if you look at 2013, it's a very small amount, that orange bar, almost minimal compared to the donation after brain death donors. But you can see the rise year after year and the exponential growth in DCD donors. And this data is up to 2023. It's expected in 2026 there's going to be more DCD donors than brain death donors in the US. Now, talking about DCD donors specifically, there's a classification for DCD donors. The most important of these 5 classes of DCD donors is class 3, and this is called the master classification. And class 3 is the anticipated cardiac arrest. So those are the donors that we anticipate that they will arrest, but this is in a very controlled setting. So we go to the OR, it happens withdrawal of life support, and then after that, we see what happens with the donor. So the vast majority of DCDs in the US and around the world are class 3 DCDs. Now, this is the timeline of events of what happens during a DCD donation. First, the donors are typically in the ICU. My mouth still. First, the donors are typically in the ICU. And then after that, when the OPO, or the Organ Procurement Organization, goes and talks to the family, and there's agreement that this will be a donor, Then after that, the patients go to the OR, or sometimes it happens in the pre-op area, and their heparin administration happens. And heparin is very important for DCD donation because it prevents any microthrombi or microclots that can happen in the vessels. And this happens before withdrawal of life support, so it's allowed to circulate in the body. Then after that, withdrawal of life support occurs. And then there's the waiting period, which we wait for around 120 minutes for most hospitals, sometimes less, sometimes more. During that period of time, we're monitoring the blood pressure, the heart rate, the oxygen saturation, and so on. And then after that, either the patient progresses or doesn't progress. When you see those cancellation emails, it's because after this process, this hour or two, patient did not expire, did not progress. So we cancel the case. Or the patient progresses and becomes a donor. So full cardiorespiratory arrest occurs. There are 2 points of confirmation, each around 2 to 5 minutes apart. So, and there's a third independent physician that goes out there and makes sure that the patient has expired according to that hospital criteria. Then after that, the patient is either transferred to the OR or he's already in the OR, the surgery starts. When the surgery starts, we obviously start by skin incision and then cannulation and cold flushing. So we go through the major vessels, cannulate it, we cold flush, remove all the blood in the patient's body. And then after that, the organs are removed and then transplant occurs. This is how it's been done since pretty much the 60s, pretty much. The same way. Now, machine perfusion came in, and there are different types of machine perfusion. There's hypothermic machine perfusion, which we use in most of our kidney deceased donors on a hypothermic pump. And there's hypothermic liver perfusion, but it's not very widely used in the US. It's still in clinical trials, actually, in the US. It's more used in Europe. And there's normothermic machine perfusion, in which there are 2 types now. There's normothermic machine perfusion itself in an ex sitio setting, outside the body, on a pump. And there's normothermic regional perfusion, in which we actually cannulate the donor and reestablish blood flow. And that's NRP, and that's an in situ organ preservation modality. Now, where do these go on this same chart that I had before? NRP starts here, directly after skin incision. We cannulate the major vessels, whether in the chest or in the abdomen, and we reestablish flow. NMP, or normothermic machine perfusion, is actually after the organ is removed from the body. So cold flush happens, we remove the organ, we put it on the machine, and then after that, the reperfusion starts. And over here, SRR, or super rapid recovery, this is how it used to be done before any kind of perfusion machines or devices. So the organ, it comes out of the body, transports to the transplant center, we bench it or isolate the vessels, and then after that, we do the transplant. So obviously, a much prolonged duration of time. So the sooner you can get this reperfusion phase, the better. So NRP is by far the soonest preservation, or the soonest time we can get reperfusion to the organs. Now we're going to start by talking about normothermic machine perfusion first. And normothermic machine perfusion is not a new concept. Actually, Alexis Carrel in 1935 tried to reperfuse the thyroid gland because the patients have hypothyroidism in order to do thyroid transplants. This was the first attempt. Obviously, that didn't go very far. And the problem with cold preservation is that whenever we put the organ in the icebox, it does decrease the metabolism of the organs, but it decreases by 97% at 4 degrees Celsius, which means that there's still ongoing metabolism. And what is the problem with cold? The problem with cold is mainly the sodium-potassium co-transporter does not function at that cold levels in hypothermia. So it cannot affect the regulation of pretty much fluid and edema intracellularly and extracellularly. So it's very important to maintain the function of the sodium-potassium co-transporter in any kind of preservation modality if we're talking about normothermic machine perfusion. So ex vivo organ perfusion in general, the questions that we had when we started our studies is first, can it eliminate ischemia? And if we're going to do ex vivo liver perfusion, what perfusate are we going to use? Are we going to use blood? Are we going to use different kinds of solutions? Or what are we going to use? What temperature are we going to run these organs at? How do we establish a large animal model, which we started with? And then after that, how can we translate that to discarded human grafts? And then after that, if we can expand this to kidney and pancreas perfusion as well. And when we talked about normothermic perfusion of organs, it was mainly targeting the marginal grafts. So steatotic livers, older livers, DCD, organs that need prolonged preservation. And the first organ that was actually normothermically perfused was not the liver, it was the lung. And that happened in the University of Toronto around 2011 or so. And they did a transplantation of high-risk donor lungs in which they put them on an ex vivo perfusion device for 4 hours, and they showed similar results like standard cold storage. In terms of liver machine perfusion, the first studies were done around 2002, and that was in Cambridge. And they perfused a pig liver for 72 hours. And this is the model that they used in terms of the pig liver. You can see the kind of like shows the reservoir up here. This was the portal vein reservoir, which brings the blood down to the liver at pretty much gravity level or gravity pressure. And then there's another pump that's connected that brings it up to hepatic arterial pressure. And this is the basis of the OrganOx machine that's used commercially right now. Now, the challenges with liver machine perfusion specifically is that the liver is a dual inflow organ. So you have two different vessels that you need to cannulate. One is the portal vein, which is a low resistant, high flow system. And one is the hepatic artery, which is a high resistance, yet low flow system. And the liver as well has higher oxygen consumption than most organs. So in order to create a circuit, you need a heart and a lung, probably a second heart that can produce a different pressure and flows in order to perfuse the liver. So translating that into an actual machine, this is how it looks like. The liver was in the reservoir. Then after that, we collected the blood from below the liver into a centrifugal pump, which ran at a high flow yet low pressure system. It gets oxygenated, it gets heated as well, and it gets recirculated again. We put a second pump up there, which is called a roller pump, and that provides a hepatic arterial pressure at higher pressure yet lower flow. And that's the dual inflow for the liver. And then we collected the bile externally. This is how the machine actually looked like in its very initial phases. You can see two pumps down there. One is the roller pump or the arterial pump and the portal venous pump. And there's an oxygenator and there's a heat exchanger as well. And the organ was obviously behind the blue drapes. Now, the model itself that we're going to use, what model were we going to use in the lab? And what questions did we have in our research protocol? First thing we asked, is machine perfusion safe? And because safety obviously is important. We don't want to do something that's not safe compared to the usual icebox. And then the second thing is machine perfusion better than cold storage? And if it is better, what kind of perfusion solution, what target temperature, and what medications are we going to use? So to answer the first question, we did a safety study to start with. And the safety study was pretty much putting organs on pump. Just regular organs, we're going to put them on pump. And what are we going to look at? We're going to look at air embolism. We're going to look at the tubing compliance, if there's any breaks in the tubing that happens. We're going to look at any hardware malfunction, pressure monitoring, flow monitoring, temperature monitoring, sterility. As you can imagine, a liver outside the body at normal temperature is a petri dish, so it can grow significant organisms. So we sent blood cultures while it's still on pump. Look at the arterial wall integrity, because we're cannulating these vessels and we want to use them for transplant afterwards. So we got to make sure that the intima was not damaged. So we looked at all those parameters, and it shows that the organs were perfused safely outside the body. And this was the hepatic parenchyma, how it looks like after 24 hours of preservation. Now, answering that question and knowing that machine perfusion is safe, we're going to move on to our second question. So, is machine perfusion better than cold storage? So, we designed a model, it's a DCD model, donation after circulatory death model, in which we waited 60 minutes after the pigs, the porcine livers, had expired, leaving them inside the body. And then after that, we either put them in the icebox, cold storage, or put them on pump for 10 hours. And this is what we call the preservation phase. After that 10-hour period, we put all the organs on pump for a 24-hour duration, and we measured multiple parameters during that time. There was lab work, there was tissue samples that we would take every 4 hours in order to assess the function and the preservation of the grafts. So in terms of lab work, we obviously looked at LFTs, we looked at CBC as well, the pH, electrolytes, bioanalysis as well, some functional parameters in terms of bile production, oxygen consumption, pressure, flows, resistances, endocyanin clearance, and looking at the histology as well, the architecture. If there's any intraparenchymal hemorrhage, necrosis, looking at it from an electron microscopic standpoint too. And the first study we published, we pretty much wanted to show how the bile duct looked, because that was the most important thing, and that's kind of the Achilles heel of DCD organ transplantation, is to make sure that the bile ducts are not damaged. And in this study, we did show that the livers that were perfused on machine perfusion had better hepatic arterial flow, better portal flow as well. Hepatic artery resistance and portal vein resistance were lower, and the pressures were better. And looking at the bile duct specifically under the microscope, the normothermically perfused livers had better H&E staining in terms of preservation of the endothelium and the peribiliary glands, which are of significant importance actually in the regeneration of the bile ducts. And we stain them with von Willebrand factor as well to look at any microthrombi that are present in the vessels or around the bile duct. And there were none as well on the normothermically perfused livers. And then we stain them Ki-67 proliferative index to look at the proliferation or the growth of these tissues or the regeneration for those organs as well. And normothermic machine perfusion was superior in all three aspects. Also in terms of LFTs, in terms of bile production, everything was heading in the same direction. So we concluded that we know that normothermic machine perfusion is a better preservation modality. It maintained lower arterial resistance and higher flows. And it also, in terms of microcirculatory derangements, there was no microthrombi in the bile ducts of the machine perfused organs. So we came to our third question. What is the best perfusion solution to use? Is it blood? Is it something else? So we compared 4 different groups. The first group was what we call the whole blood. So all the organs were just perfused by whole blood. And then there was a Steen solution group, and I'll explain what Steen solution is in a minute. And then there was a combination between both Steen solution and red cells. And there was a control group, which those were just in the icebox. So these were the 3 main groups that we had. And the Steen solution is a solution that was created by invented by Dr. Stig Steen in Sweden. And that was the solution that was used for the first lung normothermic machine perfusion trial. It's a very high albumin solution. It's a mixture between a high albumin solution and Krebs solution. And high albumin is very important for lung preservation because you need something with very high oncotic pressure to decrease pulmonary edema. So it was something that was used clinically, so we decided to use it or combine it with red cells. The reason why we wanted to combine it with red cells is that we know that the liver is a very high oxygen demanding organ. So we need an oxygen carrier in the solution. Designed a similar model again, 60 minutes of warm ischemia time, 10 hours of either cold storage, one of the 3 solutions, or the combination solution, and then 24 hours of the transplant simulation phase or putting all the organs on pump again to reassess. Whole blood obviously showed the best outcome. And the idea was that with combining the groups, the hypothermic or the combined Steen solution and the red cell group, is that we wanted something that doesn't have cytokines, doesn't have any immunologic effect. So we thought that might do better actually than whole blood. But actually whole blood did better in terms of all the groups. In terms of biliary chemical analysis, LDH in the bowel, UGT in the bowel, bicarb in the bowel as well, and the total bilirubin in the bowel. It was all superior in the whole blood group. And these were also some other functional parameters that we looked at. Megax is a lidocaine metabolite. So we measured that in the perfusion solution. It was metabolized best by the whole blood group. ICG clearance was better in the normothermic machine perfusion groups in general than the cold storage group. In terms of histology, after the 34-hour period, 10 hours of machine perfusion with the different solutions, and then 24 hours, all the same with whole blood. The one with whole blood was the best preservation modality again. The interesting part, and then the one with cold storage has significant necrosis. The one that was a combination between the Steen solution and red cells had some necrosis. But the interesting part was the one that was Steen solution only. And if you can see here that the areas around the portal triads, I'm looking at the image that's mostly closest to me. The area of parenchyma around the portal triads was the most preserved. This is when you go closer to the central vein, there's more necrosis in that area. And it made a lot of sense because once the oxygen is depleted from the solution, because there's no oxygen carrier here, the cell starts to die. So it was another confirmation that we need, exactly, in zone 2 and zone 3. So we know that we need an oxygen carrier. It cannot be just done with an acellular solution. Looked at the bile duct under the microscope again. Same staining that we used for our other studies. And again, whole blood was the most superior. And the most interesting thing was the change in weight of the organ, the delta change. And that was a sign of edema in the organs. The ones that were in cold storage had the highest amount of increase in weight, actually, of the organ per 100-gram tissue. So we know that the edema is most significant in the cold storage organs, versus the blood perfused organs actually had a loss in terms of weight, which tells us that the edema is most resolved in those organs compared to the other 2 groups. And this is how the liver looked like after 34 hours. And if you notice, that liver has 3 lobes because it's a pig liver. It's not a human liver. Now, the next question that we had is, what temperature is best? What is the best temperature that we should use in order to perfuse these organs? We designed a model that was also similar in terms of 60 minutes of warm ischemia time, but now we divided it into 3 different groups. And the 3 groups were normothermic perfusion at 39 degrees Celsius, which is the core body temperature for pigs. And then after that, subnormothermic perfusion is what we call, or that group is what we call room temperature perfusion. And there's cold storage. And the reason why we chose 21 degrees or room temperature was for multiple reasons, actually. If we can get rid of the heat exchanger, the heater, which consumes a lot of energy, and it's something important for transport. That's the thing that consumes the vast majority of energy. We want to support an organ on pump and make it a portable device. So we wanted something that can work without any organ, any heat exchanger. And the other thing is that the lipid transition phase within our cellular membrane is around 16 to 18 degrees Celsius. And that is the phase where pretty much the fat inside the cellular membrane, the lipids, transition from the gel form to a liquid form. So it means that the sodium potassium transporter, again, will become functional above 18 degrees Celsius. So 21 degrees seemed like a perfect temperature for us that the organ should work. But every time we try to change physiology, we find out that we were wrong. No, normothermic machine perfusion was still the best. So normal temperature was still the best way to go in terms of bowel production and in terms of histological preservation as well. In terms of flow of the organ as well, and also the change in weight that I mentioned, normothermic machine perfusion was superior to all different modalities, all different temperature preservations. And this is even a histological analysis, that scoring system that we improved after some studies in the Netherlands. And we used that histological scoring system to look at our bile ducts as well. And also still was superior normothermic machine perfusion at normal temperature with blood was the best way to go. Bile duct, same thing as well. Now, the last question we had was about the medications that we use during normothermic machine perfusion. And there's a lot of medications that are used, but the most important one was the vasodilators. And the reason why we thought the importance of vasodilators is that it's because of something we call the no reflow phenomena. And that develops when you develop cellular edema on the microcirculatory level in the capillaries. It can actually lead to complete occlusion of the capillaries. So it means that whether you put in blood, steam solution, whatever kind of solution you're trying to put in, it's just not going to go through. There's significant cellular edema that's preventing any kind of solution from going through the organs. So we needed a medication that can open that up only initially. If you do it in the first, usually 10 to 15 minutes, it's highly effective in opening up the vessels. Now that the vessels are open, you can reperfuse with whatever solution you'd like. So that very first phase, the first 15 minutes to an hour typically, was very important. So using a vasodilator during that phase to prevent the no reflow phenomena was important. But the more specific question we had is, which vasodilator are we going to use? So we tested 2 different vasodilators and without a vasodilator at all. The first vasodilator is prostacyclin, which is Flolan, which is typically used now for the majority of machine perfusion modalities, whether it's Transmedics or Organox. They always use Flolan or prostacyclin. And the second one we compared was adenosine. And we chose adenosine because in animal studies, we know that it has significant importance in regulating the hepatic artery buffer response in small for size grafts. So whenever you have a smaller graft of liver, when we do a liver transplant, adenosine had a major role in regulating how much blood flow is going through the portal vein and the hepatic artery. So that was the other vasodilator we used. Now, for the liver transplant surgeons in the room, or for anyone who's in the OR, they would ask us, why didn't you try papaverine? Papaverine is the most common medication we actually use intraoperatively. It did not work at all in an ex vivo setting. And we had a theory behind that. We thought because it has an indirect effect, because it's a it works by phosphodiesterase inhibition. So it has to happen, reaccumulation of cyclic AMP must happen in order for the effect of the vasodilation to happen. While the Flolan is a direct acting medication. So that was our thought, why papaverine works in vivo, but not ex vivo at all. So when we tested the vasodilators, prostacyclin had the best effects, or Flolan, in terms of parenchymal preservation, in terms of bile duct preservation as well. It shows the best outcome. Adenosine did not work that well. So now we're done with our animal studies, and we wanted to move into a preclinical phase, working on discarded human organs. Now, human organs are different because we're going to only get the discarded human organs that are not used clinically. So there's going to be a significant variation. But when we talk about pig livers, they're all the same, almost the same size, in the same amount of steatosis, the same amount of everything. They're just the same. But for human livers, because there was a variation, that variation obviously showed a significant difference between LFTs between every single organ that we used, which is not unexpected. Yet, I think is of major importance because it tells us that machine perfusion is not only a preservation modality, but it's also a functional assessment modality. We know which liver is going to work or not. As long as there's correlation between hepatic artery resistance and flows and the ALT and AST and all of the other parameters that we look at, bile production, lactate as well, then we know that this is a good organ. And that correlated as well the histology. So the histology was also showed that the livers that were doing well on pump had better bile duct preservation. Now, we had an organ that worked very well in the lab, actually. It worked up to 86 hours. So we just kept on running. We want to see how far this is going to go. And the liver did very well for almost 4 days. And the liver parenchyma was very well preserved as well. The bile duct histology was also great. No issues with it as well. One thing that did develop is that these organs started to develop some pressure necrosis, almost like bed sores, because they were sitting in the same position for 4 days. So it's something that led us to modify actually cassette that we were using during the preservation phase. And the main reason why we stopped was, well, there were 2 reasons. The first reason was that the oxygenators actually started to fail more than anything else. These oxygenators that we use are not FDA approved for up to 4 days. So we had to exchange the oxygenators a couple times. The second reason is that I was in the lab for 4 days, so I wanted to go home. Now, at this phase, we were ready for a clinical trial. And we did perform the first clinical trial in the US for normothermic liver perfusion that we placed on pump. And we got what we call an investigational device exemption from the FDA. And we placed those organs on pump, 20 cases that were needed. There were normal grafts, not marginal or anything. This was just to prove safety. And they all did very well. There was non-inferiority between the brain dead donors and the organs that were placed on pump.
I think these are back to base, right?
This was back to base, correct. Now, this was the first clinical trial that was done in the world, though. And it was started by the group in England. And in their clinical trial, they showed also that normothermic machine perfusion was non-inferior to any kind of other preservation modality. And then after that came the PROTECT trial. PROTECT trial, which Henry Ford has a major role in it. And you might notice the second name on this trial. And this study was a multi-center study that shows that normothermic machine perfusion for marginal grafts or DCD grafts had actually better outcome than cold storage. Now, normothermic machine perfusion is the standard of care here at Henry Ford, at least, for all DCD organs. Any DCD is always pretty much on machine perfusion for us here at Ford. And that has been the standard of care for the last few years, up to 3 months ago. And that's going to carry me on the second part of my presentation. So I'm going to start talking about normothermic regional perfusion now. So just for definition purposes, I mean, the normothermic regional perfusion is 3 words. First, normothermic, so it's at normal temperature. Regional is because it perfuses one part of the body and typically or always excludes the head and neck and the upper extremities. Then the region that's perfused can be either the whole torso, so the thorax and the abdomen, or it can be abdomen only. So when we do thoracic NRP, we call it TA NRP, thoracoabdominal NRP, because we know all the organs in the torso are preserved. But if we do only a NRP or abdominal NRP, then only anything below the diaphragm is perfused, but everything above the diaphragm is excluded. And it is perfusion because we place these organs or these donors pretty much on an ECMO device. And we perfuse the organs with blood during that period of time. And the background of NRP or even NMP is mainly that DCD donation, it is growing right now, but 64% of DCD donors between 2010 and 2021 were discarded. None of the organs were used. And if we look at specifically for the liver in 2021, 69% of DCD recoveries did not result in a liver transplant. And we're not talking about donors that went to the OR and did not expire. We're talking about donors that actually expired and some organs were placed for transplant. The liver was not in 69% of the time. And the main reason is ischemic cholangiopathy, the bile duct again. And also, if we end up transplanting these patients and they don't do well because of ischemic cholangiopathy, the problem is that it's not a functional problem. So these patients always have low melt. It's very difficult to get them another organ. So going back to the timeline of events, this is where NRP is. as I mentioned, directly after skin incision. We cannulate the patient, reestablish flow, usually within a few minutes. NRP is actually quite well established in Europe. And in Italy, it's almost inseparable from DCD donation. And the reason is that in Italy, they have to wait 20 minutes of no touch time. So I'm going to go back to this slide when we have 5-minute period of no touch between when the patient expires and we can start the operation, the donation operation. In Italy, that's actually up to 20 minutes. In the US, there has been delay in NRP, mainly because of ethical considerations. And it had two components. Because NRP, when it started initially, it was through femoral cannulation. So you have to send a surgeon that would do femoral cannulation on a patient that we don't know if they're going to be a donor or not. We don't know if they're going to progress and be a donor or not. So that was one part. The second part is the cerebral blood flow, because we were concerned about donor reanimation. If we're giving blood supply again to the whole donor after they die, well, maybe they're going to, it's almost like doing CPR on them using a machine. And at some OPOs here in the US right now, NRP is universally used for all DCDs. Now, the types of NRP that I mentioned, whether the A NRP, the abdominal NRP, in which we cannulate the infrarenal aorta and the cava, and the TA NRP, which we cannulate the thoracoabdominal aorta, we cannulate the arch of the aorta and the right atrium. And there's also a hybrid approach that we sometimes use. So we do venous cannulation of the right atrium and arterial cannulation of the infrarenal aorta. And this is how typically it looks like. So the vessels for TA NRP are all central, all up here, arch and atrium. Versus the abdominal NRP, the vessels that are cannulated are either the femorals or the infrarenal aorta itself. And I want you guys to take a look at the clamps that I have up there that are close to the neck. And this is where all the ethical debate happens. It's because of those 3 clamps that we have to clamp all the head vessels. It's very important to make sure that they clamp them. In some protocols, we have to clamp and vent. So that means that we put a clamp and we actually cut the cerebral vessels above the clamp to make sure that there's no blood flow at all going to the brain. So that's very important for the ethical debate that happens around NRP. Now, what's the difference now of TA NRP and ANRP? When do we use it? So TA NRP obviously perfuses all the organs in the chest and the abdomen. So if you have donation of any organs in the chest and the abdomen, it will cover that. The heart, the lungs, the liver, the kidney, the pancreas, and sometimes intestine even. It's a more technically challenging, or needs a different skill set, I should say, because it does require cannulation of chest cavity organs. For us as abdominal surgeons, it's a little bit more complex. Now, ANRP, it is abdominal, and we don't have to open the chest at all for it. And we can exclude any thoracic vessels by putting a clamp around the thoracic aorta itself. So it only perfuse the abdominal vessels, excluding the heart and lung, in addition, obviously, to the brain and the upper extremities. But when do we choose which technology we're going to use? Obviously, if the heart and lung are going for transplant, you have to do TA NRP. But if the liver only is going to transplant, when do we sometimes?
Attention, this is a code blue alert. I India 571. Attention, this is a code blue alert. I India 571. Attention, this is a code blue alert. I India 571.
So the donor identification, which approach we're going to take, is important. So if they have previous sternotomy, they had wires in the chest, if they have previous surgeries on the heart, those are not donors that we would do TA on our NRP. Because that duration of time between skin incision and the cannulation, it's usually 3 to 4 minutes. We have to be very quick because at that time, the organs are ischemic. So we got to choose the quickest phase, the quickest way we can go. So if they had a sternotomy before, we don't do TA NRP. We go straight to abdominal NRP. So previous abdominal surgeries are important to know to identify the targets of cannulation. Heparinization, although all DCDs or donors do get heparin, sometimes for NRP, if it's a larger donor, we give a larger amount of heparin. And the reason being is that we want this blood to recirculate again. We're not going to be flushing it out. So the heparinization is a little bit, has to be calculated in a different way for NRP versus a regular DCD. Now, then after that, the withdrawal of life support happens, and that's around 120 minutes. Can be longer, and sometimes in some hospitals, it's according to their protocol. And then the 2 to 5 minutes of no touch time. Then the cannulation of vessels, and then after that, after we cannulate the vessels, clamp the head vessels, we can tell them you can go on pump now. So the patient is on a heart-lung machine at that point. Everything is being perfused. During that process, after the patient is being perfused, and we have the vessel, and we have the tied off the neck vessels, and the patient is stable, we can take a breath. We don't have to be as quick as we were because the organs are now getting reperfused. And we can do a lot of organ assessment during that period of time. Get a biopsy and check the lactate levels for the donor. We can check bile production and biochemical analysis for the bile as well. And then after that, after we're comfortable, the organ looks good, everything, set the biopsy, for example, biopsy came back great. We can wait up to 4 hours sometimes and stay on NRP for a very long duration of time. After that period of time, then the organ retrieval happens. And this organ retrieval, this organ's outside the body, we can either go straight to transplant or we can put it on different perfusion devices. So it's not exclusive, either NRP or NMP. We can do both. And the mechanism of action of NRP, or the importance, is pretty much because of what I underlined here. The interruption of the ischemia injury, of the ischemic injuries that happens to the donor. So that any donor, typically, any DCD donor, typically has two ischemic injuries. One is warm ischemia time, which is the duration from when we pull out withdrawal of life support until they actually expire. And then the cold ischemia time is after we initiate the flush and all the organs are cold. Although it's better than warm ischemia, but it's still, organ damage does happen. Now, NRP interrupts those two. They're not back-to-back insults to the organ. And the key benefits are obviously the increased viability of organs and also increasing the donor pool as well, and can have real-time assessment of the organs after the cannulation process is complete. And it's decreased cost compared to normothermic machine perfusion. And the functional assessment that we talked about is not only for the liver, but for the kidneys as well. Sometimes we measure the urine output on NRP. If the patient is making urine while on NRP, then you have a how.
Attention, physical alert, H Hotel 524. Attention, physical alert, H Hotel 524. Attention, physical alert, H Hotel 524.
The challenges in establishing an NRP program come from the technical complexity. We need a different skill set. The time sensitivity, we have to be very quick in terms of cannulation. It is resource intensive as well. You need a surgeon, sometimes two. You need a perfusionist. You need machinery and equipment that moves from one hospital to another. The ethical considerations that we talked about in terms of clamping the head vessels, and the limited access and availability, because if this is usually the bigger transplant centers have the ability of performing this new technology, or the small transplant centers going to become disadvantaged. And if we look at the history pretty much of NRP, it actually started here in Michigan. At the University of Michigan, they started a study around 2005 in which they were doing femoral cannulation at that time. And after they did the femoral cannulation, they proceeded with NRP, and then after that with the donation. And they noticed that there was an increase in organ usage without decrease in outcomes afterwards. But then there was almost a 15-year period of no NRP in the U.S., while the Europeans were way ahead of us in that. And during that 15 period of time, it was mainly because of the ethical considerations. But then after that, we did the first clinical series and looked at the outcomes of NRP for abdominal organs in the U.S. And we looked at 13 livers that were transplanted from TA NRP from donors here in the U.S., in which 9 centers were included in the studies and organs from 8 OPOs. And what we noticed is that even some of the donors were simultaneous liver and kidney transplant donors, or recipients. And there was no allograft dysfunction in any of the kidneys that were transplanted. And there was no ischemic cholangiopathy in any of the organs, livers that were transplanted as well. And then we expanded to do a multi-center study in which we were included in that as well. And we looked at outcomes between 2017 and 2023 in terms of cold preservation or cold storage DCDs versus NRP at that time. And then there was significant improvement in NRP outcomes, in the outcomes of DCD livers from NRP compared to cold storage, and also a decrease in the amount of ischemic cholangiopathy and primary non-function in those organs as well. And as I mentioned, that the Italians or the Europeans in general are ahead of us, and the Italians always do what we call dual perfusion, or they do NRP first, followed by hypothermic perfusion for all the DCD organs. So they do the combined technologies in order to preserve the organs. Looking at also another important factor of NRP is that the organ utilization is higher in terms of the liver, and to a small amount in terms of the kidney as well. But in terms of liver utilization, there was a 3-fold utilization of the liver for DCD donors that were placed on NRP compared to cold storage, even if it was combined with other normothermic machine perfusion technologies. And this last study, or this other study, it looked at the utilization also here in the US in terms of liver, kidney, and pancreas. And there was increased utilization for all organs when the donor was placed on NRP compared to cold storage. And this study compared NRP versus super rapid recovery. This was a Spanish study. And what they showed, more importantly, besides the increased utilization and besides the improved outcome, is that there's increased use of advanced donor age organs. And I'll show our data briefly, but their advanced donor age was an average around 57. For our cohort here at Henry Ford, we're around 62 in terms of the donors that we were using. And this study looked at normothermic regional perfusion for DCD organs, and also showed the same as well, that NRP donors had better outcomes than cold storage donors as well. And this was a European study, a multi-center study, and all the studies showed the same outcome pretty much. Now, for our experience here at Henry Ford, we launched our program in September of 2024, and since then we've been doing advanced donor age DCDs, in which the oldest donor we used was a 72-year-old DCD. The average donor age for us was around 62 for the donors that we used. And since then, we've increased our number of transplants significantly. So in October of 2024, we did 18 liver transplants, which was a record for the program. And then we broke that record again in January of 2025, in which we did 19 liver transplants. It also allowed us to use livers for advanced cancer patients that had low MELD scores. We transplanted patients with an intrahepatic cholangiocarcinoma, and also transplanted patients who had sicker than their obvious MELD, like patients who had significant ascites or encephalopathy but had low MELD scores. They had a significant advantage from using these organs as well. So in summary, I do think that NRP will lead to a paradigm shift in DCD organ transplantation. And I do think that it is offering better outcomes and expanding the donor pool and organ utilization as well. And the future of transplant will probably show a greater reliance on NRP and NMP in the future. And this over here is what AI thinks NRP is. The only thing they thought that regional means that the surgeons are in the region because they're from the transplant itself, from the donor itself.
Thank you, Dr. Nassar. We do have some questions online, right?
Yeah. Someone wants to know, will the use of organ perfusion be affected by the current government regulatory or funding cutbacks?
The current government? Oh boy. I'm not sure I have a straight answer to that question, but the thing is that if you look at the technologies themselves, they are expensive. There's no doubt about that. They add to the cost. But there are more and more studies coming out doing cost analyses, looking, okay, well, this patient that was on the waiting list for a year or two, now they're getting a transplant much sooner. Now the hospitalization rates are less. The amount of procedures they need, whether paracentesis, whether other different hospital reasons for hospitalizations, are much less as well. So the overall cost for the patient is going to be less. And most importantly, it's going to save a life because there is waitlist mortality.
Just to amplify that, everybody knows that in the regulatory environment we're in, and that government, we're expected to transplant a certain rate, more transplant sickest first, and you monitor the med death or mortality on the wait list. You want to go down with that and improve survival. All these parameters, when you look at the current technologies we have, if you look at the cost of a transplant event, it's more money than before. But if you look at the cost of care and cost of complications at 1 year, we know that currently with some of the data that today is helping us from the orthopedics, he's heading a unit that's looking at that. That's 1 year, the aggregated cost of care of people who got DCD livers with perfusion versus without, the cost of care and complications is half compared to those who did not. So if you look at the event itself, yes, but if you look at the lifetime of a patient and cost of care, you actually see a reduction. But the total cost of care in the population will increase at some level because you're transplanting more when you look at transplant alone. But when you look at end-stage liver disease, then you actually go deeper in the hole with that. Just to amplify that.
And then someone also says, in DCD livers, how often at Henry Ford Hospital are we able to do NRP?
So our experience is only 4 months right now. Looking at the last 4 months, I can tell you that around maybe 30% of the DCD donors that we did were done with NRP as well. We're hoping to expand that even more.
Good. Anita?
The European population which uses NRP for the one scheme of time, reduction and injury, followed by the ex vivo code. For the kidney transplants, what was the code ischemia time that you used and how far did the organs travel?
So so the hypothermic perfusion that they used was for the liver mainly. Like for this study, it's for the liver. I don't know what the data is for the kidney. But the thing is that after you start NRP, I think the majority of the program in the country are looking at this donor as if it's a brain dead donor. Really, because the outcomes are quite similar from what we see. So you can consider that a brain dead kidney and put it on pump at the same time, probably.
Yeah, it's a potential.
So I have a really basic question. So 10 years ago, why did you not use 72-year-old livers? And what are you looking for now?
So right now, because of that time of reperfusion, when does that organ get the blood supply it needs again? That's the main factor what NRP changes. So because we're able to minimize that ischemic insult significantly, whether the cold or warm ischemia time, so we're looking at the donors differently. Because the donor now, used to consider them marginal because of age, but now if we decrease the insult, so can we go further and use more marginal grafts? So that's why we're looking at higher age, advanced age donors right now.
So a simple question for you. So now we have all this technology, NRP, NMP, post-storage, hypothermic. It feels like a whole mix of technologies. So I get called in the middle of the night and I get the DCD and I say, well, it looks like a low-risk DCD, or I'm not really sure, or this looks like high-risk DCD. How do you bring this dilemma at 2 a.m. when you're thinking of the three categories of, and we don't know enough, quite frankly, how each liver will respond. And how do you kind of wed this kind of clinical scenario with the technology that we have? How do you bring it together?
Yeah, so we have our protocols internally here, and there's no protocol that's very well used across the country in terms of when to use NRP or NMP or both. But I think we'll have a significant cohorts in terms of the advanced age NRP and NMP, and we can look at that data. And once we're more and more comfortable, we're obviously gonna have to drop one of the technologies and see how the outcomes are. And once we, and we'll probably do that on the less marginal grafts first, versus going to the very marginal grafts or older advanced age donor group. But we have to develop protocols. That's going to take some time.
Other questions from the group? We have an online question.
Yeah, so this person says, I know that when a donor progresses to brain death from DCD, they rerun the match runs. Is this potentially going to happen with NRP donors?
So DCD donor, you mean like when they progress, pretty much, because they don't.
It says when they progress to brain death from DCD.
That's assumed before.
Yeah, it's usually before. Yeah, the organs are covered. But I assume the question means that once they're, if there was a brain dead, if this was a DCD, and then they said that no, now it's a brain dead donor, and they rerun the match run as you mentioned, that happens even before we're in the hospital. So that happens at a very early stage in the process.
Yeah. Observational comment and question. In the early experience with the acceptance and penetration of the DCD in Europe, and they were like kind of ahead of us a little bit on that for ethical reasons. The Dutch experience reflected on a rapid increase in DCDs, and it turns out that some of the subsets were actually DCDs where either family didn't believe in the brain death process, so they wanted to see cardiac or circulatory death, or it was a convenience matter where the families wanted to proceed with either funeral arrangement. Do you see any of this playing out in your experience in the US?
So I do, and that's Maastricht Class 4 in terms of DCD classification. That's the Maastricht Class 4. And those donors, every now and then we do get them. The family wants to go to the OR at 6 p.m., for example, and we're noon right now, they don't want to do brain dead testing. But the patient doesn't have any reflexes, so we know that most likely they are brain dead. So those donors we get every now and then. But I think it's going to become more and more common as all the OPOs are going, they're becoming more aggressive about going for organ donation and so on. And it's going to be a more common thing.
Yeah. So in certain subcultures or cultures internationally, people do not believe in brain death. Now, it may be faith-based or it may be cultural. Do you think NRP in that context may shift the paradigm thinking among those communities at all?
100%. I'm a firm believer of that, and that countries that don't believe in brain death, they're going to be kind of a combined masterclass for brain death and DCD, and NRP will be a major role because now all your donors are going to be DCDs.
Yeah, and that's obviously different from extraction of organs and what they believe in and right? Yeah. Do you have questions online or no? Any questions from the group? Yes, I need.
Is the current focus on the out of sequence power placement? What will happen with the rapid perfusion?
So the out of sequence organ placement is just to make it clear, it's not something that the transplant center determines. Usually the OPO, which is a third party, they say this is an open offer.
Yeah.
So when they tell us this is an open offer, then we can go out of sequence. And there are reasons why some organs are open offers. It's because either they're marginal grafts or sometimes because of time constraints as well. The open offers are beneficial to advanced cancer patients. They are beneficial for patients that are sicker than the mouse core. The mouse core system is the best thing we have. It's not ideal. It's not perfect. So I think those patients will benefit from that.
Yes.
Is this becoming commonplace enough to where the OPOs are providing like the perfusionist and all that? Or are we traveling with all of that?
Depends on the OPO. Some
Okay.
OPOs do have their perfusionists, others don't.
Okay,
But it's becoming more and more common. Yes.
okay. Gotta lower the cost.
Uh,
Maybe.
Yeah, a little bit, not necessarily. Yeah. It just distributes the cost instead of being less cost. It waters it down on all organs.
Yeah.
The way the OPOs work. Online question?
Yeah, so this one looks like it's a comment followed by a multi-part question. Reads, one of the observed advantages to machine perfusion versus any organ that gets some time in cold storage prior to implementation is smoother, less eventful, is a smoother, less eventful perfusion. Is there hard data about this being a real advantage? Is the cost warranted? What about NRP following the machine perfusion? Can you discuss the advantage or not?
Yes, so I think the question, the part of it is about cold storage and reperfusion and how well patients tolerate it. Intraoperatively, the organs that are placed on pump, in general, patients do very well from a hemodynamic standpoint. We don't realize any shifts in blood pressure or heart rate that we see with cold stored donors. So there is an advantage when it comes to that. In terms of the addition of NRP and NMP, right now we're using it as a safety thing because NRP is a new technology. Make sure that the organs are doing well. So in order to do that, we combine NRP and NMP. We have done NRP only cases as well, but a lot of them are still NRP and NMP at this point. That's probably going to change in the future.
Yeah. When we did our first normothermic machine perfusion liver at Henry Ford in that trial, the anesthesiologist kept asking us, did you reperfuse? Nothing is happening on my side. Normally they're expecting to drop their pressure and pulmonary pressures would go up and a bunch of other hemodynamic changes. And he kept saying, please check your clamps. Are you having flows? Is the portal vein open? So he was not believing that we reperfused the organ actually after about like 10 hours or something like that. On the study, we had a minimum time on pump to get it. Deepak.
Has anyone, or maybe you did touch on this, but maybe there's a body of literature on this about conditioning organs with the machine perfusion, like immunologically conditioning. Is there any, did you guys look at that?
There are a lot of studies, but nothing that's been politically significant yet in terms of that. But yes, there are. And the biggest thing they're actually looking at is defatting livers. So steatotic livers, we can put on a pump and see how much fat we can remove. But nothing has made it to clinical use yet. But I think it will in the future.
Good question. I think that's the holy grail, right? Make it tolerant if we can.
Right.
Yeah.
Regulatory T cells.
When families consent to a DCD donation, are they made aware if it's going to be an NRP case, and is that a separate consent they have to issue?
So the OPOs are the ones that drive that conversation, but I am aware of their protocols and they do mention that to the donor families.
Yeah.
That being said, some hospitals don't allow NRP up till now in Michigan. It's because of those ethical considerations that we talked about.
I think we still have 2 or 3 in the state.
Yeah.
Other questions? Yeah, well, Dr. Mathar, thank you so much.